Our next speaker is Dr. Fariborz Neirami, and he is a consultant in pain medicine and spinal intervention at King's College Hospital, Denmark Hill. In London, many of our supporters suffer joint and back pain, starting from an early age, which is resistant to medication. Dr. Neirami will explain to us that relief is available from top to toe, and we thank him for joining us from his very busy practice. Dr. Neirami.
Thank you very much, Dr. Child. I just want to first thank you for inviting me. It's very nice to be here. It's very nice if I can be of any help. And thank you for a nice introduction. Okay, as you know, I'm a pain consultant. I've been doing my job for the last 20 years. And thank you for listening to my talk, and hope I can help and I'll be helpful to you guys. And hello to all of you. I was trying to get the information about the Marfan syndrome and back pain. When I say back pain, it's not just the back pain, it's back pain and joint pain as well. And it's the pain which comes from very early in life, and it affects most of patients with Marfan syndrome. Unfortunately, there wasn't that much big review articles in the literature. But I found some, which I linked that with the NICE guideline, which is the biggest medical body in the UK. And I tried to bring something out of both together. And I hope that helps you. The article I found is this one, which is a survey of pain therapies in Marfan syndrome. It happens in 2017, and they reviewed all the, if I go to this, yeah, that's better. All the treatments available to Marfan patients. It's very interesting, the article when I reviewed that, which I go through some of the tables for you, is very similar with the mainstream chronic back pain patients. It's not that different. In regards to Marfan syndrome, is a connective tissue disorder. Everybody knows that. And that makes my talk much easier, because when it comes to the connective tissue disorder, most of the structure in musculoskeletal system is composed of that, the same as other structures. Then you've got spinal, specifically spine, which is composed of bone, ligaments, facet joints, sacroiliac joints, any joints you can see, and those they all are related to connective tissue. And majority of patients, when they get back pain in later in life, maybe 20 years, 30 years, 40 years, 60 years or above, they've got a problem with that element, which is the connective tissue. Then in Marfan syndrome, it happens early in life. Then the presentation of the pain would be early in life. Then the whole concept of pain is the same. How we can apply it to different category of the age group of people is I think is the important factor. One of the most important things they said is that in this article also it's been raised that the pain, including back and joint pain in Marfan syndrome patients, although they have been frequently underdiagnosed and undertreated, and specifically because they've been diagnosed as Marfan syndrome. And I don't know why, if somebody has got Marfan, and then they shouldn't get the treatment or what is available. Of course, there are circumstances with the Marfan patients which makes it a degree different, but we have to take those into consideration when we use the mainstream treatment. There are pharmacological treatments, there are non-pharmacological treatments, and there are psychological treatments. The same as, again, chronic pain patients. When I go through the tables, you can see even the type of medications the Marfan patients they take for their pain is similar. There's no difference. This is the first table. at the time they did the study, they did the past and current use of different types of painkillers or interventions or psychological inputs for the patients with the Marfan. And interestingly, it shows that there has been a reduction in the pain in painkillers and other modality of pain treatment in majority of patients. They were taking more opioids before, nearly it's halved at the time of the study. At the same time, you can see there is a reduction in psychological interventions and also procedures. I think as Marfan has been raised as a syndrome which multiple involvement in systemic conditions, then there has been some kind of a trend to maybe a step back in treating these patients. That's what I'm seeing. That's what I'm understanding from this table. At the same time, you go to the type of medications they take. They take a variety of painkillers, oxycodone, hydrocodone, and to morphine, to fentanyl patch, and those are very, very strong painkillers, which I personally don't prescribe them for my patients with chronic pain. But it's been prescribed out there, and Marfan patients are not different from other chronic pain patients. Then again, what I'm coming to this is that the type of painkillers they are using is completely the same. There has been some reduction in these painkillers because for the last 10 years, there's been a nice guideline emphasis in management of the chronic pain to use less painkillers, less strong painkillers, and try to engage patients in their pain management. But it has to be a multidisciplinary approach. Not interestingly, again, the Marfan patients, when their pain is bad, they've got a strong pain, they use more morphine. The same as other chronic pain conditions. Then what I'm trying to say is that if you want to treat Marfan patients with the pain, musculoskeletal or joint pain, we shouldn't think the way we are approaching the pain management in them differently from the other patients who are suffering without Marfan pain condition. And we have to consider conditions like dural ectasia. We have to consider serious conditions like aortic aneurysm if the patient can present with symptoms which mimic the same, or dural ectasia, which can cause some risks if patient is going to have any intervention. We have to consider those. But is it the mainstream treatment is going to be different? I don't think so. It's the same as surgery for any condition or procedure for any condition. You say this patient is high risk, this patient is low risk, but it doesn't mean that you can't do it. From that point, I'm coming to this slide. This is a slide, it shows the spine from the side, and you see different elements in the spine, and it nicely divided in 3 compartments. And those compartments shows different elements that can cause back pain. Then the first thing I can tell you is that the back pain is not a disease, it's a condition. That means that back pain can be caused by different sources, i.e. if you go to the first compartment or anterior compartment, as you see, I just have running my mouse on it, you can see the vertebrae, you can see the intervertebral discs. That's the main compartment there. Yeah, there are other elements as well. Then intervertebral discs can be a part of problem. The vertebral body can be a part of problem and cause back pain. The middle compartment is a dural sac with the spine, with the nerves, with the dura itself, which again, that and blood vessels and that can be a source of pain. And the posterior compartment, which is facet joints and sacroiliac joints, which they can be the source of pain. Then, as you see, there is a 7-8 elements which the patient can only present with back pain. Our job is to find out which element is the source. This applies to Marfan patients, this applies to other chronic back pain patients. Of course, the changes in anatomy of the spine in Marfan patients can be significantly different. That can be considered. Now, based on that, we come to the NICE guideline. What the NICE guideline says about the back pain treatment, then that back pain treatment can be for anybody. For the last 10 years, there has been a significant emphasis in reducing the prescription of the strong painkiller. The reason for that is the side effects. The reason for that is dependency of the patients to it. The reason for that is morphine can cause pain after some times of usage. If you use morphine 6 months, 1 year, you get dependent to that. And then after that, your body will respond differently. There's a condition called hyperalgesia, which morphine, after having it, it causes more pain rather than reducing pain. That is why the whole emphasis of the new guidelines for the last 10 years, which I think there was 3 or 4 guidelines came out since 2008. And all of them, there's been a very significant emphasis in reduction of strong painkillers, specifically, and then they've got a guidelines on the spinal injection as well, which how they should be done, and the guidelines on medications such as gabapentin, pregabalin, amitriptyline. All those medications, they said, it has to be very, very specific area to prescribe it, and for a specific length of time. You can't have these medications forever, because you're going to be hooked with these medications, and it will have a negative effect on your treatment, on your recovery, on your feeling, sensation, mood, everything. For that reason, there has been a significant emphasis on this part. And I think the NICE has done a good job, and I can see actually the result from those tables I showed you earlier on, even in Marfan patients. But does it mean that any patient with Marfan syndrome doesn't need to have strong painkillers? No, because pain can be chronic and pain can be acute. Then if the patient is suffering from acute pain, i.e. twisted ankle, i.e. flare-up of the back pain because of a trauma, something, then yes, for a short period of time, they can have painkillers, strong painkillers, or the same as other patients, the same as any other patients with chronic back pain. They can have strong painkillers, but it has to be limited time. Then any patients come to us, we're going to risk assessment. Then in regards to the risk assessment, Marfan patients, when they highlighted with that diagnosis, they come to us or to the GP or to anybody who's going to assess them initially, that's going to be as a risk factor. Yes, that will be taken into account. And the rest of the assessment can be done. We have to always consider that, is it my back pain always what I'm thinking it is coming from? Is it only from my spine, or is there any other sources for my pain? Then there should be investigation, there should be a history taking, examination by the doctor. If there's a need, MRI, CT scan, CT contrast, all those should be done to be sure we are not missing anything sinister, i.e. cancer, i.e. other conditions which can mimic the same symptom, but they need to be dealt urgently. Then even my patient with my Marfan patient come to me, they have to be assessed thoroughly. For that reason, one of the investigations I always do is MRI for my patients, for spine. I'm talking at the moment about the spine. Then the spine patient, they need to have an MRI if their pain has been with them for a long, long time. In Marfan patients, they usually have had these investigations before from early in life. This depends on the severity of the condition, of course. If they have had any spinal operations before, if they didn't have, and so on and so forth. But MRI for me is a means that I can assess my patient, and usually after 6 months, a year, I do repeat. If there's a new symptoms, I do repeat them regardless of the time they had it before. Then investigation is a very important factor. Of course, history, physical exam, and listening to your patient is the most important thing. They come together to make a plan for your patient management. Okay, now, what is the NICE guidelines suggest for the non-invasive treatments for back pain? What do they suggest it's good to do? The first thing they say is self-management. Self-management is that get the patients engaged in their treatment. You cannot treat any patient without their engagement. See, I've got patients sometimes come, not of course not Marfan, but some patients from, for example, from city. They come to my clinic. They have got a disc problem. They have had it for maybe a month or so. He's a city boy. He wants to carry on, and he said that, "Can you please fix me?" I said, "I'm sorry, I can't." The fixing a problem is a joint venture. I can do my part, you can do your part. If you don't do your part, there is no way I can fix anything. And there is a way to do things. There is a step-by-step pattern you have to go through to get to the specific point, specifically with pain, and specifically with chronic pain. Longer standing pain always is a problem to help. Sorry, let's have a sip of water. Okay. Exercise, exercise, exercise. It doesn't matter what's your underlying condition. Fitness is the main thing. What is been ignored for a long time. Usually we try to exercise up to age of 20, 30, 35, and then we are busy with doing our work. We forget doing any exercise, or we don't have time for that, and then pain starts. It doesn't matter which group of people you're talking about. Exercise always helps. If you've got a structure such as your spine, which is weakened because of the laxity of the ligament and connective tissue, then you need to somehow make it strong. How you do that? We have a term in building industry. I use it. We call it underpinning. Underpinning is for foundation of the building. When you have a problem with the foundation, then you underpin it, you fix it. The underpinning for body, for the spine, is the muscles around it. Yes, the ligaments are weak. Yes, the bone has got a scoliosis. Yes, but if you do exercise for your life, and exercise is not for just few weeks, few months. I've done it for a week. Actually, it makes my pain worse. Yes, I know that. But if you do it and you continue to do it, it will help. Exercise is very important. And that's the thing we have, all of us, we have to do, even if without pain, we have to do it. There are other things which may apply to our talk as well. Is there any place for support, for a spine support, for orthotics, for belts, for corsets, for things like that? The first answer is a no. You have these supports if you've got instability in your spine, if you've got instability in the joint. If you don't have instability, and if you use them, and if you're not at risk of damaging yourself without them, and I'm saying that, if you're not at risk of damaging yourself without them, then by using corsets and belts, you're weakening your muscles, core muscles. Then in that way, you're making your condition worse, because it will be much, much, much more unstable. The same is for the shoes, those rocker shoes, they say it's not good. Any manual therapies? Yes, manual therapy is always good. Also, osteopath, chiropractors, soft tissue massage, all this helps. They may help for a short period, but in combination with other things, they do help. They don't have risks as such. Of course, the person who does it, they know what they do, and they should follow their instructions to do what is right to do. But are they good? Yeah. Why I suggest using that? Because there is no side effect. There is no significant long-term side effects. It always can be helpful, and it improves the mood. And when the mood is better, then the pain perception is better. Is there a place for acupuncture? They've always been asked. The new NICE guideline says no. But I say, if there is no contraindication, it's cheap, it's simple, it's easy to apply. If it helps, why not? We take NICE guideline as a serious evidence-based evidence, but we always can, based on our patients, we can suggest. And in this case, acupuncture, if there is no contraindication, I don't see any problem using that, because some of my patients, they come to my clinic, they love it, they're happy, they sleep with it. If they do, why not? Because there is no contraindication as significant side effects with that. Is there a place for ultrasound application, TENS machine, and all of these things? As you see, NICE says no, 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 no to everything. But again, TENS machine to me is something acceptable. If ultrasound for a short period helps, fine. If not, then you can stop it. these things, if we will not they are not funded under NHS, I guess that's one of the reasons they haven't been offered. And that's one of the problems, because NICE is not just based on scientific evidence, it's based on financial evidence as well. Then that is why when we use NICE, we have to think about these things. But the most important thing which has been missed is psychological therapy, pain management program, a combination of the physiotherapy and psychology together. This has been missed and it's been raised, even this article, which I said in 2017, that is the most important factor in patients with Marfan syndrome. They need this as a base for their treatment. And honestly, this is an underfunded area. I have put business case for that multiple times where I was. And unfortunately, it didn't happen because somehow you can't transfer the message. Seems to be that not always injection, not always medication, not always surgery is the solution, but this is the solution. When you come to the end, yes, you do all those things, but you need this pain management program as a way to help. And there's lots of strategies the patients can use, and use those strategic, scientific strategies to deal with their feelings, because it is not just the pain and body pain. It's sometimes the patients, they get depressed because of what they have, and they need those strategies to help them. And to me, pain management program is important. And for Marfan syndrome, I should suggest that they have always to be seen in a specialist center with whole facilities. Yes, we can help patients here or there, but they need multidisciplinary approach, because it is not just the spine which is going wrong. It is not just that, it's everything together. And because of that, the psychological approach input is very important. That's what I said. And one of the things we say for chronic long-standing patients is a return to work. I say, get engaged with your society. If you can go to work, go to work. If you can't go to work, go to a charity, go to social events, engage. Engagement takes mental focus off. It is important to have a healthy body, but at the same time, we need to have a good attention to what is right for us, what is not right. It is not good to sit in the corner. Go into the society, go talk to the people. If you can work, perfect, return to work. If you can't, then get engaged. That's right. That's my message on that. Medications. We had a brief chat, but as you see, if a patient has got sciatica, specifically in Marfan, they can have referred pain because of the impingement syndrome in the back, specifically if they have ectasia. Then is the morphine is the solution? No. Morphine medication, again, is for short period, not long period. They can be tried on gabapentinoids, pregabalin, gabapentin, amitriptyline, those medications to some extent. Benzodiazepines, if anybody get prescribed for diazepam, please don't take it. Diazepam is a no medication. It's very addictive, has got no specific help. It helps for one day, maybe with the spasm, but after that, it's very addictive. It's worse than morphine. Is there any place for low back pain treatment? Low back pain treatment, we usually say anti-inflammatories, paracetamol, cocodamol, and measures like that. One can say that what happens in Marfan patients, because I have had, for example, a spinal fusion. I don't respond to this medication. I think, yes, they have to be checked and reviewed in tertiary center, in multidisciplinary team, to be given all the information and treatment at the same time. It is not possible to fix the back pain, even if you've had a spinal fusion for 10 years, 20 years, with morphine only. It just makes the matter worse. That's what I can say. It has to be seen in a multidisciplinary team. As you see, there is lots of do nots, which the guidelines suggested, which I already said that. Is there any invasive treatment? I have to say that because of the condition with the Marfan, and specifically spine, some percentage of patients, 60% or so, and they get dural ectasia. Because of that, there has been a significant move back from intervention in this group of patients. With new technology we have, with the MRI, with everything we have, we can help with the patients with interventions, specifically those patients which their pain is coming from, if I go back in my slide, this posterior column. Because the posterior column has got nothing to do with the dural space. Posterior column has got nothing to do with the nerves. Posterior column is a facet joint and sacroiliac joint. They don't have anything to do with the dural ectasia. Then, on the other hand, significant percentage of the back pain, about something between 50 to 70% of back pain in patients without Marfan or with Marfan, it comes from just posterior aspect, not in anterior. Then the posterior aspect is the target to work on. Is there anything possible to do? Yes, I go down now. Yeah, there is a spinal injection we do as a facet joint injection, but that's a test injection. We test the injection, the case, to see if there is any benefit. If there is a benefit, there is a radio frequency denervation can be applied, and it can have significant effect in regards to the pain relief. It's a posterior column of the spine. It's got nothing to do with the ectasia. It can help with the pain, even if it takes away 50% of your pain. It helps. Then definitely it's a nice guideline behind it. I suggest that. Epidurals, more yes and no. If we've got an MRI, if we know that the patient has got no ectasia or other problems, it's a possibility. If there is a, maybe in the shape of nerve, maybe nerve root injection, but we need to know exactly what we're dealing. Then in case of sciatic pain, there's a possibility that we can do these injections in Marfan syndrome, provided they don't have underlying problems. Is there a surgical intervention? You know that there's lots of surgical interventions, which in this case, in Marfan patients, happens from early in life, not late in life. Then they can have fusion, Harrington rods, it used to be like that. And as they grow, they may need further operations on their spine, and it's mainly because of instability of the spine, which I'm not going to go into that, it's not my area. But yes, there is a definite place for the spine. And I'm showing you this as a for example, this is a facet joint, where we can do this injection here as a test, and then we can do radio frequency. This is a facet joint injection. These are different slides, and let me go. This one, for example, you see that there's a needle coming from outside, and that's the outside the spine, that's outside the facet joint. The spinal canal is here, and when we can catch this nerve, which causes back pain. That's the probe of the radio frequency. It goes to that nerve, which is outside the spine again. The sacroiliac joint is very important. I have to say that sacroiliac joint, as you see, this is a photo of the sacroiliac joint. This is a ilium, this is a sacrum here, but you look on the bulk of the ligaments sticking these two bones together. Then if you've got the laxity in this ligament, then you definitely have got a sacroiliac joint, and then definitely can be treated because it's out of the spine. The sacroiliac joint is easy to treat. You can do a simple injection as a test, and then you provide the radio frequency for that. And the pain usually is around here, but even the pain can go down in the patient leg as well, sacroiliac. See, this is nothing to do with the spine. This is the pelvis, and we inject at the base of the joint, and then we do the treatment, which is radio frequency. As you see, this is a radio frequency probe outside the spine, under the muscle. We put it there, and we ablate the nerves. And it gives the patient 1 or 2 years pain relief, which helps. Now, we had a lot of talk on the subject of the spine, but the same application of the nerve block and radio frequency applies to the hip joint, knee joint. And my patients, they can have problem with the hip or knee. And usually they come to me because they can't have the surgery. It is too risky for them to have the surgery. They are too young to have the surgery replacement, or it is too late for them, or there is a medical condition underneath. For that reason, they can have application of the radio frequency to the hip joint, for example. Then it cannot be applied to the Marfan patients with the same kind of a condition and same risk. There's no increased risk for the Marfan patient to have this. Or you can have it for the knee pain. If you don't want to have knee surgery, you can have the same approach to the knee. These are nerves outside the knee joint, and we numb them, and then we apply the radio frequency. And that helps them. It helps with the pain. 1 year, 2 years pain relief. And if you come back, it can be done again. And there is another condition, kyphoplasty. It doesn't apply that much in Marfan, but just put it there that it can be done easily. And the disc operation, we can do it percutaneous disc operation without going off to sleep, specific cases. And this one, the last one, is the one which is spinal cord stimulator. I noticed some patients with the Marfan syndrome, they have been tried on having a spinal cord stimulator. I guess those patients are only without dural ectasia. But if the patient has got a long-standing fusion or problem with the spine and they have had multiple surgeries, that's one way as well, but that's going to be the last step. It has to be lots of investigation, lots of assessment, lots of multidisciplinary approach, and then decision be made if the patient is suitable for this. Then, as you see, I think what I can say, Marfan patients suffering from musculoskeletal pain, the same as other patients with the chronic pain. Marfan patients, they've got different conditioning, make them slightly different when you want to approach the pain management. But at the end of the day, majority of techniques can be applied. Is there any intervention can be done? Yes. Surgical, I'm sure my colleagues there have spoken about that. And I'm happy to listen to you guys if there is any question. Thank you.
Thank you so much. I'm sure there will be a lot of questions, but if I could just kick off with the first one, I'm sure a lot of the patients are thinking, where do I go in my area to find this kind of help?
I think any pain consultants in your area with in any different secondary hospitals, the help I just explained about the intervention at the end, the radio frequency injection, they should be able to provide that. Some hospitals are much more available, some less. If you go to tertiary hospitals, as I said, in Marfan patients, maybe it's better to have a review in tertiary hospitals from the beginning to have a multidisciplinary approach, not just one aspect. Then, for example, Guy's, King's, UCL, you name it, all of them, they have got facility. But even in secondary hospitals, majority of patients, they can have access to that.
Thank you. Victoria, do you have any questions from the patients?
Yes, questions have flooded in. Mary wants to know, does a Tarlov cyst cause pain? It was found on an MRI, but no comment on its presence from medics.
Yes and no. It can be normal finding. It can have no significant effect on the pain. It can have some effect. It depends usually in the size. It depends in the location. It depends if it causes any pressure effect. If there is a query about that, they can have further investigation like nerve study, EMG study. Sometimes it helps. But cyst on its own, we see it a lot in the MRI, and not all of them subject to a specific treatment or surgery. But we can see them, yes.
Jacob would like to know how to locate a multidisciplinary team. He's in Southampton. Okay.
The main hospital, the tertiary hospital in Southampton, should have the facility for pain management program. If you approach the pain management team in your hospital, in the local hospital, the central hospital, of course, I don't know how many hospitals you got over there, but the central hospital over there should have the pain management team. They should have a pain management program at the same time, because that's a must-have now for any area. We should have a pain management program.
And Mary would like to know the best way to ask the GP for help with back pain that will not go away. In her case, it started badly in 2019 and will not improve. She was told it was due to Marfan, but it was not debilitating before. Also, her elbow and wrist are painful now.
Okay, then again, the new guidelines, and I don't know where she is, but the new guideline specific for the commissioners is that the patients should get referred after initial assessment by the GP and the physio. They go through the specific treatments, conservative, as we said, which because the main emphasis at the moment is on that. And unfortunately, what I've heard from my patients, there is not much hands-on physio input. It's just mainly paperwork input, which is not helping, specifically the patients which need to be told exactly what to do. But at the end of the day, when they do the assessment, usually they do the MRI scan as well, investigations, and then they refer them to the pain consultants, to the secondary hospital, if they think there is a need, surgeon or tertiary hospital. If they have had this pain for a long time, they can ask GP to directly refer them to the pain management program. If they can go tertiary, would be better.
I don't think anything further has emerged from the chat feed.
In that case, I think perhaps it's time to break for coffee, and I'm sure Dr. Neirami would like a coffee as well.
Thank you very much.
Thank you very much for taking time out of your busy life. And do enjoy the rest of the afternoon. And if we have any more questions, then we'll make sure that they're directed to you. But we'd also like your permission to put this talk on our website.
Please do.
Because it's one of the most frequent questions we get from patients. Most of them do, 70% of them suffer from joint pain at some time in their life. So thank you very, very much.
Thank you
for enlightening us.
Thank you for help.